This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Fellows Conference. Your speaker this morning, as you can see, is Dr. Elena Dolmatova. Elena is in our basic science research track. She's originally from Russia, where she went to medical school at Moscow State, came to the United States, did a residency at Rutgers, and then did 3 years of research in Dr. Grinling's lab. And is now in her first year of clinical training. As you can see, she's going to talk about Doxorubicin induced cardiomyopathy. Dr. Dolmatova.
Good morning, everybody. Doxorubicin is a chemotherapeutic agent that has been discovered from streptomyces and is most widely known for its use as in treatment of breast cancer, triple negative breast cancer, but actually is used for a number of different liquid and solid tumors and childhood tumors as well. And the mechanism of action is thought to be twofold. One of them through the direct DNA damage to DNA alkylation and topoisomerase 2 inhibition. And the second is by reactive oxygen species formation. And why those two mechanisms are very helpful in fighting cancer, they are also the culprit of all the other complications that we can observe in the chemotherapy, with one of the most feared ones being the doxorubicin-induced cardiomyopathy that can present even years later after chemotherapy has been already done. Who is at increased risk for cardiomyopathy? And there is a definite dose relationship with the magic number of 500 milligrams per meter square, which is debated, and some of the researchers say it is actually lower than that. There's increased risk if you're a woman, if a person is older, more than 65, if it is a younger child, less than 4 years old, if there is also radiation therapy, if there are other drugs that are being given at the same time, and if person has already pre-existing cardiac condition. We might ask what's happening with the genetic predisposition, and I also was questioning that. Unfortunately, the studies that are available today suffer from lack of power, and even the genome-wide association studies don't have a very good power to detect polymorphism associated with that. That said, at this time, there is a good evidence of genomic regions around the genes associated with sarcomeric structure and function, topoisomerase 2B expression, drug trafficking, drug metabolism that are associated with increased risk of doxorubicin cardiomyopathy. Despite we have some evidence towards that, none of that met the threshold of being something that we can use in screening of patients prior to chemotherapy administration. So how do we diagnose doxorubicin-induced cardiomyopathy or any sort of chemotherapy-induced cardiomyopathy? We are looking at the ejection fraction of the heart, and it has to satisfy both of the criteria. It has to be more than 10% change in ejection fraction to a value that is less than 53. And as I said, it has to be both. So if somebody had ejection fraction of 65 and after the chemotherapy it became 55, it really doesn't qualify to be a chemotherapy-induced cardiomyopathy. It should be confirmed by repeated cardiac imaging within 2 to 3 weeks after first detection. And doxorubicin is a type 1 chemotherapeutic, meaning that it's causing irreversible damage by causing damage to the cells in a dose-dependent manner, which is in contrast, for example, with trastuzumab, which is causing reversible damage, but in combination, they might be even more toxic. So the most common way to assess the function is by 2D echo that is available almost everywhere. And the most preferred method of ejection fraction calculation is modified biplane Simpson technique with the method of discs. It does have its limitations, and if you add resting wall motion score based on 16 segment model. It increases sensitivity of the method. If there are 2 or more segments that you cannot see of the endocardium, you can benefit from using contrast. And unfortunately, as we all know, there is about 10% interreader variability between different echoes. So if you have this 10% and you want to detect the change of 10%, that becomes not a very sensitive tool for detection of such changes. 3D echo is gaining speed and actually is better than 2D echo, but because it is accounting for other things in the left ventricle, not assuming its shape. But unfortunately, it's not readily available everywhere as of this moment. We all studied for the boards at some point, and we all remember Mugascan as the one that is preferred for the chemotherapy detection when we label the blood and we can assess LV ejection fraction. It's actually better than 2D echo in accuracy and reproducibility. It's comparable to 3D. And actually lacking some of the technical limitations the echo would, such as it can be easily used in obese patients, patients with poor acoustic windows, patients with devices. But it has its drawback. It subjects people to radiation, which is not always desirable. And with modern systems, there is a debate that it may not allow for the best positioning as the ones that were actually described in the studies first. The question is, can we benefit from detecting subclinical LV dysfunction? And probably yes, because then we can adjust and change the chemotherapy before we already have the LV dysfunction. There were a couple of things that were suggested to be able to detect subclinical LV dysfunction. Initially, diastolic function was suggested, but unfortunately, it was lacking positive predictive value. Then the tissue Doppler imaging was also thought of being useful. Again, as you know, there is some angle dependence in how you position the probe for the mitral annulus tissue imaging. And because of that, the repeated measures might be affected more by angle than by the change in the tissue Doppler values. And finally, the most novel thing is the global longitudinal strain, which actually is angle independent and allows for assessment of all the segments of the left ventricle, not only mitral annulus at the same time. And it is thought that reduction of global longitudinal strain 15% from baseline is very likely to be abnormal, but that number hasn't quite yet made it into guidelines. And finally, all of those parameters, the diastolic function, global longitudinal strain, or even ejection fraction are load dependent. And then when you have a patient on a chemotherapy, the volume status of this patient changes quite a bit. So strain rate was suggested to be more sensitive because it's relatively load independent compared to the other measurements. And finally, MRI is a gold standard for left volume assessment, as you might know, but it also has a potential for subclinical detection with late gadolinium and T1 mapping, when you can look and see if there is early fibrosis or inflammation, therefore detect the potential LV dysfunction in the future rather than detecting when the AEF already is down. Biomarkers was suggested to be helpful, with one of the most obvious ones being a troponin. However, at this time, there is a question about exact timing of troponin measurement. Where exactly after the chemotherapy would you measure it to have the best result? And of course, the cutoff points of where to increase sensitivity and specificity, because not every troponin elevation will lead to the LV dysfunction, and where exactly we draw the line at this time is not quite clear. Natriuretic peptides were also suggested, but it seems like they reflect the volume status more than the LV dysfunction in the future. And as I mentioned earlier, volume status of people on chemotherapy can change dramatically. So what are the mechanisms of doxorubicin-induced cardiomyopathy? And if you look at any RNA-seq data of any cell type that you dump doxorubicin on, what you will be having troubles with is to find a gene that is not changed. It doesn't leave a stone unturned. And that makes it very difficult to understand what exactly doxorubicin does and what is the mechanism of the toxicity. With that, most of the consensus is around a couple of points. A lot of that is revolving around mitochondria and oxidative stress and impaired mitochondrial function and increased mitochondrial iron, which is also kind of connected with the disruption of calcium 2 homeostasis. A little bit of a different theory is that doxorubicin binds to topoisomerase 2B, and together they promote DNA damage. With all of that, upregulating expression of death receptors and leading to cellular apoptosis. It's all nice, but how can we prevent the doxorubicin-induced cardiomyopathy? And not surprisingly, the first things that people thought about were the standard heart failure therapies like beta blocker, ACE and ARB, and those are the trials that try to look at it. They're fairly small number trials, and the outcomes there might be not always perfect. And they would look at mortality instead of like LV function, for example. So there is a way to go in terms of having more trials on those. There was a lot of preclinical trials suggesting that statins may be having anti-inflammatory effect in preventing LV dysfunction, but there are only 2 small clinical trials that are available at this time. And if you can see, actually, there is a recent meta-analysis looking at ACE, ARB, and beta blockers in patients that were received chemotherapy, and it is favoring use of those drugs for prevention of chemotherapy-induced cardiomyopathy. So we have these drugs, but there is one drug that is actually specific to the mechanism of doxorubicin toxicity. And what we have a lot of iron in the mitochondria, and it's being transported in and out. There is a whole movement of the iron. And what is thought to be happening is doxorubicin may be binding directly to the iron or inhibiting its transport out of mitochondria, resulting in the accumulation of iron in the mitochondria, which is toxic and produces a lot of reactive oxygen species. Doxorubicin is capable of binding this iron and pretty much chelating it out of mitochondria, preventing the mitochondrial damage. But there are some suggestions that it may decrease tumor response because of this reduced reactive oxygen species that may be also having chemotherapeutic effect. It it increases myelosuppression, and there's possible risk of secondary malignancy, which actually hasn't been proven to be true. But because of those fears, right now it's only advised to be used in people who would receive higher doses of doxorubicin, or in people who are suspected to receive more doxorubicin in the future. The one question that bothered me a lot, and I didn't see much of a data on that, is like, if we are working a lot and trying to prevent the cardiomyopathy, but whatever drugs we use, how would they affect the chemotherapeutic effect of on the tumor itself? Because if we're preventing chemotherapeutic effect of the doxorubicin on the tumor, we are having a different problem in our hand, where we actually not achieving the treatment goals, right? And all the basic science studies that you can look at, they're looking at cardiomyopathy, and they're really not focusing on the tumor effect of those drugs at all. With the exception of one small study that I was able to find, where they looked at metformin, carvedilol, and enalapril, and control here in black, and looked at cytotoxic effects of doxorubicin when these drugs were introduced. And luckily for us, it seems like there was no effect of these drugs on doxorubicin toxicity, meaning that this doxorubicin was still able to have its chemotherapeutic effect on the breast cancer cells. The same held true for the dexrazoxane. It was also not affecting the chemotherapeutic effect on the cell, on the tumor cells, and that all is in vitro. So there isn't really in vivo data on that. But what it made me think is that if we have things that are cardioprotective, but are not affecting the chemotherapeutic effect, there must be some difference in how this tumor toxicity versus cardiotoxicity are happening. And maybe it has something to do with the types of cell. They're very different cells, right? Tumor cells are dividing rapidly and they're mostly glycolytic, and cardiac cells don't divide pretty much at all. And they're mostly dependent on oxidative phosphorylation, although they can switch to glycolysis if need be. So my thought was that maybe there is a difference in the toxicity mechanism, with tumor being mostly affected by the DNA intercalation inhibition of topoisomerase 2, and cardiac muscle being affected by oxidative stress and impaired mitochondrial function. Now I want to switch gears just a little bit. I was working in Dr. Green's lab, and it's working on protein named POLDIP2. It's not a very famous protein, but it is very multifunctional. It was first described as a polymerase 2 associated protein, and polymerase data associated protein, and it was involved in DNA repair. It also is found in other parts of the cells, but the nucleus, and it was shown to be involved in metabolic switch and reactive oxygen species formation. You can see here there is a lot of overlap with what I just said with doxorubicin toxicity and the cardiac toxicity. So what I initially thought was that maybe reduced POLDIP, if we knock down POLDIP, we'll be able to be protective against doxorubicin-induced cardiomyopathy. And to test that, we had our POLDIP2 knockout mice, or wild-type mice, and we injected them with doxorubicin. And 5 days later, we assessed cardiac function, serum troponin levels, and mortality. And here you can see mouse echocardiogram. And at baseline, there is a nice contraction of the heart and left ventricular valves coming in nicely. But after you treat the wild-type mouse with doxorubicin, it develops acute doxorubicin-induced cardiomyopathy. However, in a knockout mouse, you don't see this effect. It's still contracting nicely. And if you are to quantify that, you can see that there is significant reduction in ejection fraction in wild-type mice, but we don't see this reduction in knockout mice. And we wanted to see if it correlated with troponin levels, and similarly, wild-type doxorubicin-treated mice had significant increase in serum troponin, while the knockout mice did not. Finally, when we injected these mice and just observed them over time, you can see that all of the wild-type mice were dead by the 3 weeks of looking at them. At the same time, all the knockout mice were still alive. Oh, nice, but I was still kind of wondering what is the mechanism of protective effect, which one of them is important, because as POLDIP being multifunctional and doxorubicin having so many different mechanisms, which one is the key? And that's when I turned my attention to the recent paper showing that POLDIP2 knockdown is able to switch from the oxidative phosphorylation to glycolysis. So if you knock down POLDIP, the cells would become more glycolytic. That's when we thought that maybe what's happening is that in cardiac muscle that is normally dependent on oxidative phosphorylation, we knock down POLDIP, it switches to glycolysis. And after treatment of doxorubicin, because the mitochondria is not as functional, there is not that much oxygen moving around, there is less reactive oxygen species formation. At the same time, in breast cancer, there's already glycolytic. When we knock down POLDIP, there would be little or no effect on the metabolism. And after treatment of doxorubicin, the same effect as we talked about earlier with DNA intercalation, DNA damage would just be still there. To test whether that was true, I just first wanted to see if knocking down polyp would affect the apoptosis. And we had our cell culture with the H9C2 cardiac myoblast cells and BT549, the triple negative breast cancer cells. We can knock down polyp using siRNA and treat with doxorubicin, and then assess apoptosis by looking at the cleaved caspase. As you may remember, during apoptosis, number of caspase get cleaved and cleave each other and finally cleave other proteins. So cleaved caspase 3 is thought to be a classical apoptosis marker. And here you can see the Western blotting results on cardiac myoblasts, and we have a vinculin as a loading control here, looking that all of those are loaded equally. Then we probe for polyp. We can see that we can knock down polyp with the cypolyp quite successfully. And when we looked at cleaved caspase, you can see that in control cells, there is quite a bit of increase in caspase 3 with doxorubicin treatment, which we would expect. The cells are dying. But if we knock down polyp, we have much less of cleaved caspase 3, indicating that the cells are dying much less when you knock down polyp and treat with doxorubicin. And if you quantify it here, you can see that there is significantly less of caspase 3 in the SI polyp. Well, it's nice that we have it in the cardiac myoblast, but again, my continuous question, what happens to the tumor cells? And if you can look at the tumor cells, I'm sorry, I need to fix that because otherwise it's going to be beeping forever. And in the tumor cells, again, you can see that they're all loaded equally. But if you knock down polyp, here and here, you can see there is much less polyp. And you look at the cleaved caspase. Again, with the doxorubicin, you see quite a bit of increase in cleaved caspase. However, if you knock down polyp and also treat with doxorubicin, you see that it's not unchanged, it's not decreased. As a matter of fact, it's increased. So if you knock down polyp and treat with doxorubicin, you actually promote apoptosis in the tumor cells. And here's just the quantification. So it seems like we are able to kill two birds with one stone. If we knock down polyp in the heart, we're protecting the heart from doxorubicin-induced cardiomyopathy, or at least protect the cardiac cells from death from doxorubicin toxicity, but we are also able to increase apoptosis and increase death in the tumor cells. Well, siRNA is a nice research tool, but it's very hard to deliver siRNA in the whole organism, especially in such a big organism like a human. So we were looking for something more pharmaceutical that we can apply that would work through somewhat similar mechanism and would be able to decrease polyp. And luckily for us, there is one drug, ONC201, that is actually activating CLPP protease in the mitochondria. And it causes a few effects, but one of the ones that we care about is that it's actually able to decrease polyp by just degradation of that polyp. So we wanted to see if the addition of this drug or pretreatment with this drug that is now being developed as chemotherapeutic drug for glioblastoma would actually have similar effect to the ones we observe when we knock down polyp with siRNA. And again, we tried to do it in our cardiac myoblasts. Again, it's loaded evenly. And if we add this ONC201 to the cells, you can see that polyp 2 actually does go down. If we treat the cells with doxorubicin as before, there is an increased caspase 3, cleaved caspase 3, indicating initiation of the apoptosis. But if we pre-treat cells with ONC201, there is significant less of the cleaved caspase, meaning that the ONC201 pretreatment is capable of preventing apoptosis cardiac myoblasts after doxorubicin administration. And when we do the same with the breast cancer cells, again, we can see that ONC201 does decrease polyp 2 levels in breast cancer cells, but it doesn't decrease the apoptotic effect of doxorubicin. If anything, it maybe increases it slightly, not to the same degree as a SI-PODIP, which seems like it does mimic to some degree, at least, the effects of SI-PODIP on the cells, and opens some other opportunities to try to prevent cardiomyopathy with minimal or even opposite effect on the tumor. So in conclusion, we have decreased PODIP that in cardiac muscle, and after you administer doxorubicin, would prevent doxorubicin-induced cardiomyopathy. While in breast cancer cells, it would kill breast cancer cells. And as of now, we don't have much of a data. We have hypotheses and preliminary data here and there, but what we suspect is happening is that the prevention of doxorubicin-induced cardiomyopathy is performed through the inhibition of reactive oxygen species, while the promotion of apoptosis of breast cancer is done through the DNA intercalation and topoisomerase 2, and actually enhance the effect of those effects of doxorubicin, because PODIP2, as I mentioned earlier, was involved in DNA repair. And it's quite possible that if you knock it down, the DNA repair is happening even less. Therefore, the chemotherapeutic effect of doxorubicin is promoted. And finally, we do have a drug that to some degree mimics the effects of SI-PODIP and able of decreasing PODIP2 and possibly having similar effects on the muscle and the breast cancer. So of course, it's just a very preliminary, and what we would like to do is to kind of expand on that thought and expand on those findings. And first, we would like to figure out what's happening in terms of the mechanism. And again, we would take our cell culture models and we would knock down PODIP or give ONC201, we treat with doxorubicin, and we would look further at different other caspases that are activated in different apoptosis pathways and see if there is a difference in those. We would look at mitochondrial function, reactive oxygen species production, and finally look at the DNA damage in those two different cell types. Ultimately, what we would like to do is to do something that would be able to assess those two things in the whole organism, because everybody's looking either at the tumor treatment or at the heart, but very little is known about what's happening if you do it in the same organism. And to do that, we would have two models. One of them would utilize wild type and PODIP knockout mice, and we would inject wild type of PODIP knockout tumor cells. We would let the tumor grow, and then we would treat the mice with doxorubicin and assess cardiac function, serum troponin, cardiac fibrosis, tumor growth, and mortality to see how doxorubicin under those conditions would act on both the heart and the tumor growth. And ultimately, we would like to have just normal wild type mice, normal wild type tumor cells, and treat the mice with ONC201 before administering doxorubicin, and look at the same parameters and see if by administration of ONC201 we can prevent doxorubicin-induced cardiomyopathy while either not affecting the chemotherapeutic effect or possibly even promoting chemotherapeutic effect of doxorubicin. So in conclusions of this kind of scattered talk, doxorubicin is a common chemotherapeutic agent that can cause irreversible cardiomyopathy. While multiple risk factors have been identified, no doxorubicin-specific screening strategy exists at this time. Early detection is getting easier with improving technologies that we have right now. The mechanism of cardiotoxicity likely involve mitochondrial dysfunction and oxidative stress. Dexrazoxane is approved for prevention of doxorubicin cardiomyopathy, and standard heart failure therapies are also promising. And finally, the mechanism-specific prevention strategies, I think, are warranted, and more research is needed to try to figure out if we can actually prevent cardiomyopathy while still maintaining the chemotherapeutic effect of doxorubicin on the cancer. With that, I would like to thank everybody who contributed to this work one way or another, with all the very nice collaborative atmosphere in the basic research side, and of course the funding that supported this study as well. And if you have any questions, I would be happy to answer.
Thank you, Elena. Very good, interesting review and of both the clinical and the research side. I don't have any questions at the moment. Any questions from the group?
Elena, this is Dr. Jerry McGorris. What is the thought mechanism of statins in preventing or protecting the heart in chemotherapy-induced cardiomyopathy?
So the thought was it mostly anti-inflammatory effects.
Okay.
So, and most of that was, as I said, it's mostly preclinical studies in the rat and mice models. But yeah, their thought was that they inhibit the inflammation, different stage of inflammation, like either the vascular or the immune cell infiltration, but an anti-inflammatory part of it.
Okay. Thank you.
Yeah, this is Andy Smith. It's great that you're looking at this. It's a really big clinical problem that we see in the heart failure world. And just a comment, the patients who develop this, they sort of behave in some ways more like a restrictive type cardiomyopathy than necessarily a dilated cardiomyopathy. They don't get as much ventricular dilatation as sort of what we see in non-ischemic idiopathic cardiomyopathy. And they may be less likely to tolerate some of the guideline-directed medical therapies, in part because of that. Another comment is that in our heart failure group, we're often asked to see patients who develop cardiomyopathy, but got the doxorubicin as children. And it's been reported that children who get doxorubicin 20 years later may be diagnosed with toxicity. And one of the common things that's seen, if you look back through their pediatric records, is that they often have a resting tachycardia and a higher heart rate. It's something to consider, but certainly a major problem. It's a drug that's used very frequently and is quite an issue for us in the advanced heart failure world.
Actually, I think in part because of what you said with the restrictive pattern of the cardiomyopathy, the strain imaging and strain rate imaging might be of a bigger value than just standard LV ejection fraction measurement, because by the time you decrease the LV ejection fraction, it might be too late. So I think that's probably quite definitely part of why people are moving towards more advanced imaging in detection of the cardiomyopathy. And of course, the modeling of delayed cardiomyopathy is very challenging, but even acute cardiomyopathy is challenging in the animal models, but especially delayed doxorubicin cardiomyopathy is a huge challenge in terms of how to model it in the animal model, mouse, shall it be mouse or rat or anybody. So that's one of the things that I'm afraid on the basic science side of things may not necessarily evolve as fast as we would like.
Yeah, Elena, as an echocardiographer, that's usually my involvement with these patients is on the front side with their echo pre, chemotherapeutic or echo following along. But you're right. I mean, it's, at least in the past, the guidelines technically had recommended radionucleotide imaging because it was a more accurate assessment of ejection fraction. But you're right. The echo does provide certain advantages. You mentioned the lack of radiation. You mentioned the portability, particularly for an ill hospitalized patient that a echo can provide, as opposed to MUGA. but also, like you said, the sort of preclinical markers potentially that assessment that you could have with echo, like you said, of strain imaging, looking at diastolic function, even things of that nature that might manifest abnormalities even before the ejection fraction starts to drop. So, and I don't know if the guidelines have been updated for this particular chemotherapeutic agent, whether they recommend either MUGA or echo, sort of give the choice. I know here locally, I feel like it's probably more echo than MUGA these days. But is any other thoughts on the pre-chemotherapeutic assessment of ejection fraction?
My view on that slightly skewed because the guidelines I was looking at were mostly from the American Society of Echocardiography, but yes, they do recommend the baseline echo.
All right, well, very good. If no other comments or questions from the group, we'll thank Elena for her talk this morning, and we'll look forward to seeing everybody next week at conference.
The preceding program is copyrighted by Emory University.